So as we go through these, I just an acknowledgement to Dr. Snehal Bhatt. I'm using his slides with his permission, and I appreciate that from him. I think I don't have any relevant financial disclosures. We will be talking about some off-label dosing of buprenorphine. And I think because of that, this talk can get rather confusing. So with that ahead and with looking at the objectives here, one of the things, my computer, let me move monitor a little better so I'm looking. So I think to me on this, and I want to go through this and to give you an idea where I'm going. Number one, I want to go over what the package insert says to do. I realize that we don't really follow the package insert on buprenorphine initiations, and that utilizing a low dose or microdosing, a Bernese method, whatever you want to call it, is much more common in the fentanyl era. But again, I think just to be aware what's on the package insert, I think is important. I will typically say, hey, give patients the choice between the two when we're doing the induction. And then I also want to cover a little bit about the injectable products. I've got a question to the group too, and if on my learning. So and my question is, have you been needing prior authorizations to initiate either Brixadi or Sublocade? There's only 2 injectables around, so I feel comfortable using the trade names of the drugs. So if you could just put that in chat on the prior authorization, would appreciate it. And then we're going to talk about potentially on patients on the discontinuation of buprenorphine. So as far as the formulation goes, it comes as a film or a tablet. My experience, and again, most of my work now on starting patients have been in variety of clinical studies and being more in a consultation role. So if something has changed here in 2024, feel free to bring that to my attention. So primarily in the prescribing, this is going to be dictated by the insurance company. And will they cover the film or the tablet? To me, and if I'm unsure, I just put on the prescription, okay with pharmacy substitution film or tablet, whatever's doing it. A couple of years ago now, I want to say it was 2022, the FDA added a warning that the film and the tablet increases the risk of dental caries. This isn't a reason not to pursue this. What the recommendation that I and other experts basically do is, hey, you should just get your every 6 months evaluation of your teeth by your dentist. And if it becomes an issue or we think there's an issue, we'll talk about it. As far as advantages of the self-administration versus the injectable product, I think most of us are favoring the strip or the film just because it is prior authorizations and the cost has I don't know why that happened, has been much easier. There is an increased risk of diversion. There is a street market value to buprenorphine. I think some of the studies that have been done investigating diversion have pointed to meeting an unmet need of individuals. It's so possible. So the injectable, the implant, I need to change this. The implant is no longer available. We've got a growing body of clinical expertise. Again, the tablets or the films have been out for much longer. We have more experience. There is a really high compliance. The patients show up once a month to the clinic and they get their shot, or they go to their specialized pharmacy. There is a higher cost to it. You can't, I don't know of, and I haven't found any cases of people being able to divert. the injectable buprenorphine. I do find as a first-line treatment, the injectable for my teens, I have a real strong preference for that whenever possible. But like I said, I've been hearing some reports that prior authorization for most insurers are no longer needed. Historically, you had to fail the sublingual first. So again, I'm curious to see what your thoughts are in the chat. And when I reshare the screen, I'm not able to see the chat at this time, but I'll review. So this is where we're going down the package insert. And I'm going to go over this relatively quickly because I'm not doing this anymore. I don't think Sergio's doing this much. And in our talks here in the fentanyl era, it made everything more complicated. And I think this is a good time to kind of pause and to give us a reminder that the days of that these and the studies of these slides were based on were the good old days of primarily heroin and OxyContin, and those days are over. So, but basically what we wanted to do was get the patients to a COWS score as high as possible, preferably over 8. If we get them up to 12, that was preferable. And so we would send them home and tell them the minimum of 12, realistically 24 hours since their last dose. And then we would start them on a low dose on about 4 milligrams of buprenorphine, and we would repeat that every 1 to 3 hours for their withdrawal symptoms. If they precipitated withdrawal on what to do, we would have them call the clinic. And basically, for those of you who precipitated withdrawal back in the fentanyl, or I'm sorry, the pre-fentanyl era, we just basically would hit them fast and hard with a bunch of bupe. I think we started with a low dose to make sure the patient tolerated and titrated up a little bit slow for it. But I think the challenge for a lot of our patients was, you pretty much have to take a day off of work or a couple of days off of work to be able to do the induction because you're just not functional, feeling completely miserable. A lot of my patients never struggled tolerating the level of withdrawal that they needed to do the initiation and basically tapped out and went and used, which kind of delays it. Again, I think to me, principles of carpe diem, to quote the French, seize the day, is a little bit better way to go. On day 2, we would basically take the total that they took on day 1 to control the symptoms in the morning, and then try to check back with the clinic to let us know where they're at, and then that way we can basically navigate or titrate them into their dose. The goal was to get patients up to 16 milligrams, as that was really where suppression of the cravings and withdrawal symptoms that occurred. And you'll notice I'm using past tense here. In the fentanyl era, there's an emerging number of reports now that are highlighting that 16 milligrams is probably insufficient for the majority of patients. I know that's my experience as well clinically. And Sergio and I have talked about this, and he'll correct me if I'm wrong, which is great having him on. But I think that's his experience too. So, my goal is 20 to 24 milligrams, with that kind of needing to generally demonstrate things didn't go super well on 24 milligrams before escalating to 30 or 32 for the day. On day 3 is basically can really try to get them on that 16 milligrams daily, and then give the patients a little bit of liberty, or I've always given them some liberty to kind of practice splitting those strips up. Some of my patients like to actually have cut one of the strips in half, and be able to space it out further. Others are fine with twice a day. So there is some variation on the end person. There's talk on how long to wait based on the duration of action of the pill. I don't want to spend much time on this because we're not doing it too much. The transition to methadone, and I think this is just identifying how we've moved away from this whole process of waiting, converting them down to 40 milligrams or less for at least a week, and then provide the symptomatic support and starting at a 4 milligram and titrate up. Precipitated withdrawal, this is something to just, even now is very relevant to discuss what happens ahead of time. I think those of us who prescribe this to more than probably 5 to 10 patients, we've now encountered patients who are afraid to initiate buprenorphine because it's induced withdrawal with them in the past, and usually worth a conversation. But I think if patients kind of know or waiting or ahead of time have a heads up, I think a little bit of withdrawal being anticipated and knowing that it's going to get better is managed better by patients, and they tend not to freak out or become concerned that the medication isn't working. Freak out is probably not the right word to use, and I recognize that, but I also recognize that, I give them something, they start withdrawing, they want to go use, and this is usually early in my relationship with a patient, and I don't, on the addiction side, I don't have that patient that I've known for years or months where they trust me and can just give me a call and say, yeah, that induction didn't go well, doc, and then I've been using, isn't something that they're generally at that point in care comfortable with. So this is basically an introduction to a low dose method. So going back to the slide on transitioning from methadone to buprenorphine, this is actually what Bernice originally did in demonstrating the really low dose buprenorphine and titrating up. This is just one dosing regimen that's out there. I would, in the last 2 years, 3 years, I would say I've seen at least 4 or 5 different studies that have looked at or published in the peer-reviewed literature their dosing induction, and it all roughly follows the same thing. Again, things that I've talked with my partners about is I haven't had any problem starting somebody on a 0.5 milligrams on day one. I haven't, and some of this also gets into how many times are you going to cut the slip or the tablet. And to me, like for example, at UNM, they refuse to cut it at all, and so cutting a tablet 4 times, there's variability in the dose, and there's a little dust and things so that come. The strip may be a little bit easier, but again, are those really 4 equal pieces? And then as I can get that, but then cutting it into 8ths and cutting it in half again gets to be a little bit much. And then basically taking that, doubling the dose every day until they're at 16 milligrams. Takes roughly a week. Now, the other way of doing it is more aggressive or a clinical approach, as I do, is so you ask the patient, how do you feel? You wake up in the morning, I feel miserable, I'm starting to withdraw. Okay, take a 0.5 milligram strip, and 30 minutes later to an hour, it's either going to make you feel better or worse. If you're feeling worse, I go ahead and use, and you'll feel better immediately. If you're feeling better, great. Do you feel relief? No, I'm still not there yet. Then it's basically just work on increasing that dose. If they do use, then I just basically have them try that dose like at bedtime or late in the day. And usually they, within 24 hours, they're tolerating it, has been my experience. Does that make sense? Hearing silence, I must not have objections. All right. So FDA has buprenorphine with a max dose of 32 milligrams. Most insurances do, as I said, will cover up to 24. Usually when they come at 24, and we need to increase it, I just write them for a few extra strips, and then begin the paperwork. The duration of the prescriptions, I think some of this is tied to what's going on in our clinic. How backed up are we? What are the resources and things the patient has? I to me, I personally like to try to follow my patients up in the beginning weekly. I know there's some evidence which suggests that every other week probably works better. I just like having a check-in a week later, just in case, or that I need to make a dosing adjustment, which seems like I frequently have to if I'm going to 16. And then as the patient is doing well or stabilized on that dose, as they start getting their lives back together, then start backing it off to monthly. My patients who are doing really well on it, I write them for a month with a 1 refill, and then just kind of have them, check in. As far as watching for diversion or management, some periodic random drug screens, checking their PDMP. We can do a 48-hour callback, and basically where we're giving them, notice that here you need to come to the clinic within 48 hours and bring what you have, in the strips, and just looking at the count. Part of my counseling to my patients is like, look, if I was an oncologist, you had cancer, part of my job would be to screen you for return of the cancer. Part of my job as an addiction doctor is, to periodically screen if in case you've relapsed or something. At the same time, if you relapse, that's something that I'm not going to give up on you. And it just means that we need to focus on the treatment plan and probably make some changes to it. Doesn't mean you're a bad person or you failed or anything. It's, again, we need to talk about making changes to that treatment plan that works better for you. So these are some the low dose inductions, and I'm just going to go through these slides kind of quickly because all the information on here I've pretty much discussed up to this point. All right, so finishing here on stopping or the duration of maintenance. So I think number one is, in every study that we have up to this point, when patients come off of buprenorphine or methadone, that we start seeing them relapse and we start seeing them come out of treatment. Since for 50 years now, methadone has been approved by the federal government to be on patients as long as it benefits them. From an ethics standpoint, the current opinion is that patients are on MOUD as long as the patient feels that it benefits them. To me, on my patients with MOUD, none of them want to be on it chronically, or most would rather not be on it chronically, because hey, I'm like my patients. I don't want to take a pill every day. I think there is some discussion on that does need to happen with the patient. I think when they are on the strips, that they will, whether or not I agree with it, they will try withholding strips and seeing what happens. We know that within the first 16 weeks, we have a really high relapse rate. So for my patients, I say is we need my recommendation, we need to give the buprenorphine a minimum of a month trial to make sure that it's effective with them. Beyond that year, we can look to start cutting down. The thought is again, this is what I tell my patients, is that we need time to restructure and get your lives back together and define what a new normal is. And I will, and to that end, I like to start my how are things going question with, what successes do you have to share with me today, to make sure that they're recognizing that their successes and where they're improving. from a science standpoint, basically all the clinical studies that have gone out to a maximum of a year, and again showing people withdrawing or stopping care up to a year. So the data really isn't very robust beyond a year. On those, when we have a discussion for whatever reason that we're going to decrease or cut down the taper, I have a discussion with the patients that there is a high relapse rate and overdose rate is there. This is the time to, to make sure that they have their home naloxone, and that they call the clinic immediately if they're having a loss of their or the return of their cravings, they're having withdrawal symptoms, as it might mean that the titration is too fast. And also let them know that they may have lost their tolerance. When it's the case of naltrexone, that they definitely have lost their tolerance, and so provide some education that, I know you used to do 20 bucks of fentanyl was no big deal for you, but remember, you're now at a fentanyl level like me, who's a complete newbie to it, and my body's not going to tolerate those doses. I also give the patient some freedom, because if I don't give the patient freedom, they're going to do it anyway, to slowly kind of titrate down as they can tolerate. Usually, this slide has them tolerating 28 over a month. But if we need to do it slower than that, it's at the rate that the patient tolerates. Once the discontinuation is done, we want to make sure they've got functional goals that are meeting stable social networks, and then really want to, following cessation, this is another time to increase the frequency of visits and continue to do some screening. And I am also cautious about praising patients in this period of time, and just say, I'm here to support your personal goals. My personal goal is to maintain you in recovery, and however that is, because I don't want them to feel that they're a failure if they were unable to titrate themselves off. There can be considerations to a naltrexone depot injection following discontinuation, to kind of help make sure cravings and things are under control. That's, I know, is currently under investigation in clinical trials. Hopefully we'll have the results here in a couple of years.